Good morning, everyone, and thank you for joining us for updates in pediatric cardio-oncology, hosted by Hart University and sponsored by Sophia's Hope. I'm Dr. Melissa Hudson from St. Jude Children's Research Hospital, and I will serve as the moderator for webinar number 4, which will focus on the role of risk prediction models in guiding cardio-oncology care. I'd like to introduce our first speaker now, Dr. Eric Chow. Dr. Chow is a pediatric oncologist and epidemiologist at the University of Washington and the Fred Hutchinson Cancer Center. He serves as the medical director of the Cancer Survivor Program at Seattle Children's Hospital and chairs the Children's Oncology Group Outcomes and Survivorship Committee and the Childhood Cancer Survivors Study Chronic Working Disease Group. His research is broadly focused on outcomes of survivors of childhood cancer and survivors treated with blood and stem cell transplantation, with a specific interest in identifying risk factors for cardiovascular complications in cancer survivors, which he has translated into risk prediction models to facilitate survivorship care and clinical trials evaluating health-promoting interventions in this population. His presentation will describe the development and validation of an individual risk prediction model for heart failure among childhood cancer survivors. Dr. Chow.
Thank you, Melissa, and thank you to Sophia's Hope for sponsoring today's session. So let me go ahead and share my slides. So just a quick disclosure, I do receive some research funding for Abbott Labs. That has no relevance to today's presentation. And so I think just as background to make sure the audience is all up to speed, obviously there's an increased burden of late cardiovascular disease among survivors of childhood cancer, as well as adult onset cancers. And this seminal paper from the Childhood Cancer Survivor Study published by Kevin Effinger showed that there's a significantly increased relative risk of heart failure, as well as other serious cardiovascular diseases compared with siblings. And expanded data from the CCSS published more recently show that compared with the older treatment era from the 1970s, patients treated more recently in the 1990s had a decrease in various late effects in the endocrine and second cancer domains. However, we don't see the same reduction in late cardiovascular disease in this more recently treated cohort, and therefore this remains a significant issue going forward. Childhood cancer survivors also appear to have poor cardiovascular conditional survival. Again, this is data from the Childhood Cancer Survivor Study that Wendy Botnor and us published or presented last year at ASCO 2021, and showed that once someone is diagnosed with a major cardiovascular event, whether that's heart failure, coronary artery disease, or stroke, they appear to have greater cause-specific and overall mortality compared with their siblings. And so here in the diagrams, the siblings are on the left, the survivors on the right. The red part of the curve shows the cause of deaths that's related or due to the specific cardiovascular condition of interest, whereas the blue represents mortality from other causes. And so you can see for each one of the panels, the top panel being heart failure, the second panel being coronary artery disease, and the third panel being stroke, that the red sections as well as the blue sections are greater for survivors compared with siblings and across all panels. So this begs the question from a risk prediction perspective, can we create data-driven individual level prediction to guide more targeted surveillance and interventions? Most oncology screening guidelines are consensus-based, and we think that general population cardiovascular risk estimators are likely inadequate. So the example that we have here is a 35-year-old man, white non-Hispanic in this case, who's a bit overweight with a BMI of 28, has normal blood pressure, not on medications, has a total cholesterol 170 and HDL of 36, also not on medications, does not have diabetes, and is a non-smoker. So you can plug this scenario into one of the pooled risk models or the Framingham model, and you will get a 1 to 3% risk of heart disease in 10 years. But what if the same person had Hodgkin's lymphoma at age 13, treated with anthracyclines, say doxorubicin 300 milligrams per meter squared, and mediastinal radiation of 23 gray? We suspect that that person probably will not have the same risk as predicted by general population risk estimators. So to address this, we were interested in using data from the Childhood Cancer Survivor Study, which is 5-year survivors from 31 centers, now from 1970 to 1999, looking at 3 specific outcomes. We'll focus on heart failure for the purposes of this talk, but also looking at ischemic heart disease and stroke. Using the CCSS definitions, we limited this to grade 3 and higher, which are self-reported conditions with medication corroboration for heart failure, any heart transplant, and then death records, so death related to heart failure. Our goal is to predict individual risk by age 50. We wanted to use readily available inputs to make this clinically meaningful. So sex, diagnosis, age, chemotherapy exposures such as anthracycline alkylators, platinum agents, vinca alkaloids, and then radiation, including brain, neck, chest, and abdomen. Use conventional statistical metrics to describe our model, including area under the curve, receiving operating characteristics, and the concordance or C statistics. And these metrics just show that when you have a prediction model that's no better than chance, you'll have a line essentially across the middle. And the idea is to push that red dotted line over to the left-hand corner, where then you would be associated with 100% sensitivity, 100% specificity. So for this modeling purpose, we examined 3 separate models. One was what we call a simple model, where we only had information on yes, no to exposures. So you had anthracycline such as doxorubicin, yes or no, but not necessarily having dose information. We then created a standard model, which had both the chemo and radiation target dose. So someone who's treated with chest radiation of 10 gray or 15 gray. And then we had a heart rate dose, which is a heart model, which was standard radiation, standard dosing of chemotherapy plus heart organ specific dosimetry. And when you look at the heart radiation and chest radiation comparison of the doses, you can see that they're highly correlated. Although as expected, there are certainly individuals who receive high levels of chest radiation, but who may not necessarily receive the same level of heart radiation. This is data courtesy of the group at MD Anderson who does the radiation dosimetry for CCSS. So moving along to our risk prediction modeling. From a training perspective, again, we had CCSS data from about 13,000 participants for this analysis. And in this initial effort, we only had data available from 1970 to 1986. We still had about 300 cases of heart failure through age 40. And again, the ascertainment was self-report with medications and death records. And you can see for our various AUCC statistics that we achieved reasonable values in the 0.7 to close to 0.8 range. And as expected, the model's accuracy improved with the increased sensitivity of data available. For validation, we had access in great collaboration from 3 groups, one from the Netherlands, from what is now Prinses Maxima, which had at that time a single center data set of about 1,400 patients. And in contrast, had medical records, death records, and some clinical assessment. We also had information from the National Wilms Tumor Group, which was a clinical trials group focused on kidney cancers. And again, medical and death records, as well as self-reported medications. And then lastly, we had the St. Jude Lifetime Cohort, which at that time was about 1,700 patients. And again, similar to the other 2 validation data sets, had medical and death records and some clinical assessment. And so the important point is that these 3 validation cohorts ascertained our outcomes a little bit differently than CCSS, which mostly relied on self-report. And I'd like to just again acknowledge the collaborators from those 3 institutions, led by, for the Netherlands, Lika Fayen, who was a grad student at the time and has since, of course, received her PhD, is on faculty now. The late Norm Breslow, who's the longtime PI of the National Wilms Tumor Study, and of course, Melissa Hudson as a PI of St. Jude Lifetime Cohort Study. When you look at the validation results, you can see that they're, as expected, were a little bit variable. Results from the Netherlands and the National Wilms Tumor Study were fairly similar. St. Jude was a little bit slightly lower, but not dramatically different. St. Jude also at that time had a requirement of 10-year survival and age 18 or older in order to enter the cohort, which is now shifted. So those slight differences may also account for some of the variation from CCSS. Result is we're able to create a series of risk scores corresponding to the available clinical inputs. So you can see for male, female get 1 point. There's an increased number of points assigned with earlier age at cancer diagnosis and treatment. Anthracycline dose, not unexpectedly, is associated with higher risk, especially as the dose increases, and similarly for chest radiation. And the result is you can have someone in this scenario who's an 8-year-old girl, therefore gets 1 point, diagnosed with ALL at age 3, 2 points, who received a certain amount of anthracyclines, alkylators, and vinca alkaloids, but no radiation. And as a result, this person would get 6 points under our standard model. And then this can then be assigned into different risk groups, such as low, moderate, high. And you can see for this person, potentially because of their age, young age at treatment, as well as having a female sex is associated with a high risk group, or this group then is associated with having a cumulative incidence of about 12% at 40 years and relative risk over 40-fold compared with siblings. We've since extended this data to age 50 and beyond. And when you plot this as cumulative incidence curves over time, you can see that the 3 groups, low, medium, and high, segregate into discrete curves. And this similar pattern can be seen in our validation cohorts as well, showing here the data from Emma Children's Hospital from the Netherlands. We also looked at other outcomes as noted earlier. So we also looked at ischemic heart disease and stroke. And you can see we had similar number of cases, and similarly use the same strategy of using widely available clinical inputs and identify which ones are reasonable predictors. And you can see the performance noted below, around 0.7 for ischemic heart disease, a little bit lower for stroke. We also were interested in looking at the role of conventional cardiovascular risk factors. Here we extended data up to 1999, and we had upwards of nearly 23,000 survivors of childhood cancer from the CCSS. And we know that conventional cardiovascular risk factors increase with age. And as a result, we created separate models corresponding to looking at people at age early 20s, mid to late 20s, early 30s, and late 30s, as the burden of cardiovascular risk factors will be different across each of those time points. And the goal here is also, again, to predict outcome by age 50 and to predict 10-year risk as well. And I forgot to mention earlier, but I do want to acknowledge Yan Chen and Yutaka Yasui, whose photos I think were in the earlier slides, but were covered by my video screen. And they really did the yeoman's work of the biostatistics, creating these models, and just want to make sure that I acknowledge them as key collaborators in this entire effort. So here, using age 35 models as an example, we can create risk scores for each one of these 3 cardiovascular outcomes, but then also add in the information from diabetes, dyslipidemia, and hypertension. Again, this is using CCSS data guided by medication use for each one of these conditions. And you can see here, looking within the CCSS, where we have reserved 50% of the cohort as discovery and 50% for replication, that we achieve reasonable performance across all 3 domains, even when we incorporate the conventional CV risk factors. And also importantly, you can see that in some cases, they have nearly the same impact, if not more, than many of the conventional treatment risk factors that we normally think about, especially like diabetes with a risk score of 3 in the terms of stroke, having a value of 2 for heart failure. And so that just reminds us it's so important that these potentially modifiable risk factors should be screened for and addressed in survivors of childhood cancer, especially as they get older. These plots on the right just show the calibration of the models across each of the age groups for both what we call our standard risk group as well as the high risk group. And you can see that the predicted and the observed values are fairly similar within roughly 0.1% of each other, suggesting that our models are reasonably well calibrated. These are all available online through the CCSS website at St. Jude. There's a short URL noted above. And so you can use this model and plug in the same scenario where, again, we have that 35-year-old man that I previously described, where, again, the general population risk factor models would predict a 1 to 3% risk of serious heart disease in 10 years. But if you factor in his lymphoma treatment with anthracyclines and chest radiation, what you see instead using these models is you see a much higher risk of heart failure, ischemic heart disease, both at 10 years and also by age 50. So just a couple other considerations as we close this section of the talk. Are there additional refinements we can use for clinical inputs? We've since shown that anthracycline equivalence ratios need to be examined and have evolved as a result of some of the research that our group collectively has done. And as one example led by Lika Fayan, where she took the same data set, we looked at mitoxantrone risk in relation to doxorubicin and found that even after adjusting for what was conventionally held to be a fourfold increased toxicity of mitoxantrone, we still saw a significantly increased risk of mitoxantrone beyond doxorubicin, somewhere in the range of about 10-fold risk. We also are interested in looking at heart radiation dosimetry, specifically dose volume relationships. And James Bates and Rebecca Howell have done some really nice analyses where they've shown that both getting low dose across large volumes of the heart as well as high doses to small volumes of the heart are important. And being able to incorporate that level of detailed information may further enhance prediction beyond our cruder clinical treatment dose fields that we used in our models, as well as even our heart organ-specific average doses that we used. And then finally, what are the impact of cardioprotectants? For example, currently within the COG, we're looking at the long-term efficacy of desoxane and seeing if that modifies late cardiotoxicity. And so showing that and then needing to incorporate that into future risk prediction models may be another way to go. And then finally, other studies such as in COG, the AAML current trial 1831 is interested in looking at liposomal formulations, again, as an alternative strategy for reducing cardiotoxicity. We also are aware, obviously, of the introduction of a wide variety of new agents, many of whom have at least acute cardiotoxicity, although their late effects are less well understood at the moment. And so over time, as more information comes out about these agents, they may or may not be needed to be incorporated in their future risk prediction models as well. And then finally, can genetic and other biomarker information improve prediction? And so there's obviously been a wide number of polymorphisms in genes implicated in the anthracycline moderating and cycling toxicity. And there likely is a role for incorporating them at some level into future risk prediction as well. And then as a prelude to one of the third talk of today, can we use imaging biomarkers as another way to further enhance our risk prediction and surveillance strategies? And so in data that we've shown with working with groups at Emory, Sick Kids Minnesota, and City of Hope, we've shown that even several years before someone is diagnosed with cardiomyopathy, that there are significant differences in multiple echo parameters that are typically read as part of your standard echocardiogram, 2D echocardiogram. And so the hope is these models can then further improve positive, negative predictive values of screening and surveillance. So with that, I'll stop.